Hope you have a thumbs up if everything is okay. Am I audible, visible? Yes, and can we start? Yes, am I audible, visible? Okay, so it is a session, very interesting session, where I'm going to take FMG Recall Physiology. I'm going to cover as much as possible MCQs which have been a part of your exams, right? So let's get started with this. And if there is anything like if you find that, ma'am, please help us know, so you can let me know if there is anything to discuss. Chalo. So let's get started with the first question. Okay, now here's your mentor at Unacademy. So let's get started with Dr. Reena. Now there is a child or there is a person with a history of vomiting. Now once there is vomiting, what kind of disorder, acid-based disorder, are you expecting? Metabolic acidosis, alkalosis, or respiratory acidosis or alkalosis? So come up quick so that we can, do as much as questions possible. Yes, so all those who are watching, fatafat come with the answer. So what is the clue? When the person is vomiting, he is going to vomit out the contents from the stomach. That means primarily a loss of H plus ions. That means if there is loss of H plus ions, there is an indirect gain of bicarbonate. So therefore the answer is going to be metabolic alkalosis. Yes, any problem? Is it clear? Very good, very good. Very good. So yes, now I can see all of you discussing. So it is metabolic alkalosis. Now bachas, just one clue I'll give you. Whenever you get an arterial blood sample or whenever you get a question that is related to this, तो आप क्या करेंगे? The first thing you will always look upon is the pH. Definitely if the pH is less than 7, it is acidosis. If it is more than 7.4 or less than 7.4, acidosis or alkalosis, right? The second one which should be always taken into consideration should be your bicarbonates. So definitely if the acidic pH is there and the bicarbonates are less, it is metabolic acidosis. If it is if the pH is more and the bicarbonates are more, it is metabolic alkalosis. Now in very important thing is, suppose if the pH is acidic and the bicarbonates are also more, then what I do? How is this possible, ma'am? If it is acidosis, how the bicarbonates are more? So in such a case, when there is acidosis and the bicarbonates are more, then just consider it is respiratory acidosis, and in that case look to your partial pressure of carbon dioxide, because in this case the bicarbonates will be raised as a part of your compensation, right? As a part of your compensation. So make it very, very clear that if it is pH is acidic, look at the bicarbonates. If the bicarbonates and the pH, they are going in the same direction, no problem. But if the bicarbonates and the pH, they are in opposite direction, it is a kind of compensation. This question is repeatedly asked, and therefore I really thought that I should consider this. So metabolic acidosis, one of the important causes which we have seen is renal tubular acidosis, diarrhea. Now in diarrhea, what you are losing is the intestinal contents which are rich in bicarbonates, and therefore metabolic acidosis will be there. Ingestion of acids or chronic renal failure. Likewise, metabolic alkalosis, vomiting, diuretics, aldosterone, or ingestion of some alkaline drugs like sodium bicarbonates, which are given in patients with chronic gastritis or peptic ulcer. So this question is repeatedly asked. Metabolic acidosis is one of the very important question. I mean acid-base imbalance. If it is respiratory condition, obviously the bicarbonate, partial pressure of bicarbonate is going to be raised. any condition that results in respiratory obstruction, damage to respiratory centers, or even ventilation perfusion mismatch, or even if the patient is having respiratory paralysis, any condition where there is accumulation of carbon dioxide, and carbon dioxide being a volatile acid is going to result in acidosis. That will be respiratory. Respiratory alkalosis, that is CO2 washout. One of the very important physiological cause is high altitude. So one important MCQ is that with high altitude, a very important the phenomenon which you are going to get is an alkaline urine. So this question is frequently asked. So this comes to the end of the acid base. Second important question, let's move forward. Which of the following is the action of dopamine at low doses? It increases the renal blood flow, it causes vasoconstriction, it has got a positive chronotropic effect, or it causes hypotension. So bachas, come up fatafat with your answers. What is the action of dopamine? Yes, dopamine is a vasodilator, right? It is a vasodilator. Very good, Deepak. It causes increase in the blood flow. And I have got another option. In that option it was written as a positive inotropic effect. So that effect of dopamine is also acceptable, that it also causes positive inotropic, that is it causes increase in the force of contraction. Remember that dopamine is something which also is causing diuresis and natriuresis along with ANP, because both of these can bring about the relaxation of the mesangial cells and they bring about increase in GFR. So increase in the renal blood flow and increase in the GFR is one of the important action. So it causes renal vasodilatation, it causes natriuresis, it is produced in the PCT also, where it inhibits the renin secretion, right? Moving on next. Hormones and endogenous substances that are involved in the regulation of calcium balance are. So जैसे आपको मैंने बताया कि this metabolic or the acid base balance is very important. Similarly, if you go through calcium के ऊपर there are many questions like hormones regulating calcium or calcium binding proteins. So what is the correct answer? Definitely Dr. Nissi has given up the first answer very correctly. So what should I give you? Definitely I should give you some treat. Yes, very good. So it is vitamin D, PTH and calcitonin. So just add on to this. How to add on? Now suppose there is an increase in calcium and there is increase in phosphate. This hormone is going to be vitamin D. Suppose there is decrease in calcium in the plasma and decrease in phosphate. This hormone is going to be calcitonin. But there is a hormone which causes increase in calcium and which causes a decrease in the phosphate. This hormone is PTH. One of the very important function of PTH to be remembered is that this PTH or the parathormone, it causes increase in the calcium reabsorption from the distal tubules. So it causes increase in the distal tubular reabsorption of calcium, but it causes phosphate urea. तो MCQ आता है कि phosphate urea कैसे cause करता है? It causes decrease in the phosphate reabsorption from PCT. So all is P, that is P for parathormone, P for decrease in the phosphate and P for decrease of the phosphate in the proximal tubule. It inhibits the sodium phosphate co-absorption transporter. ठीक है, sodium phosphate co-transporter is inhibited by your PTH. Next one. There is an elderly person who is coming with following symptoms: tremors, rigidity and bradykinesia. Which neurotransmitter is involved? Dopamine, acetylcholine, adrenaline or serotonin. Now see, tremors are something which can occur with either cerebellum or they can occur with basal ganglia. But whenever you get bradykinesia, that is the paucity of movements, so it becomes basal ganglia. That means degeneration of the dopaminergic neurons of the nigrostriatal pathway, and therefore the correct answer is your dopamine. So see, you See now, dopamine is a very very important neurotransmitter. Mithu has given the first correct answer. Very good, Mithu. So let's celebrate this with ice cream. It's very very hot. So dopaminergic neurons, nigrostriatal pathway, dopaminergic neurons, mesocortical system, nucleus accumbens and limbic areas. This mesocortical system, you must remember, it is involved in the reward behavior and addiction. And this nucleus accumbens is supposed to be your center, this center is actually a kind of an addiction center. Okay, it is an addiction center. So addiction to simple tea, coffee, or addiction to even alcohol or are because they are acting upon this addiction center. Now next question says that there is a person who developed the symptoms of dementia and was diagnosed with Alzheimer's. Which neurotransmitter is involved? Fatafat. Dopamine, acetylcholine, adrenaline, or serotonin. So definitely when it is dementia, when it is Alzheimer's disease, the neurotransmitter is acetylcholine. Very good. Yes. Nosy, doctor, very good. Good guys. A very good, answer and wonderful, lovely interaction. It is acetylcholine. Remember, one of the very important function of acetylcholine as a neurotransmitter is memory. Okay, so just look at this slide. Neuromuscular junction mein there is acetylcholine. Acetylcholine is in the basal forebrain complex. Acetylcholine is involved in learning, memory and regulation of the sleep-wake cycle. Acetylcholine is also responsible for the REM sleep. The PGO spikes, which are the important components of the REM sleep, are because of acetylcholine. Moving on next. The vitamin that increases the absorption of iron from stomach is vitamin A, B12, C or D. What is the answer? Correct answer, fatafat, so that we can just have a rapid revision of many MCQs. Very good. It is vitamin C, ascorbic acid. Very good. So remember the factors that increase the iron absorption. It is ascorbic acid. The site where iron absorption is there, duodenum, and those which decrease are phytic or the phytes, that is phytic acid, phosphates or oxalates. As far as the iron absorption is considered, you must remember this figure, which is I have taken from Genong 26th edition. This is on the luminal side, the important transporters which are involved. This is DMT1. DMT1, which is the divalent metal transporter 1. Divalent metal transporter 1, that is responsible for the reabsorption of iron from the apical side, where there will also be an enzyme, that is ferric reductase. Now on the basolateral side there are two important things. One is this ferroportin and hephacetin. Ferroportin and hephacetin. But again, if you are asked iron absorption will be by the divalent metal transporter 1 because it is present on the apical or the luminal side. This figure is from Genong for your further revision. Now, next important question. A patient was given halothane for general anesthesia. He develops rigidity and hyperthermia. These symptoms are because of which iron? Yes, come up. What is this condition? This condition is a condition where there is a mutation. That means it is a mutation of a channel, so it is a channelopathy, and definitely it is calcium. Now you tell me which calcium channels, in the T tubules or in the L tubules? T tubules or L tubules? Which channels are involved? So the channels which are involved are the rhinodine channels. The rhinodine channels which are present on the L tubules. Very good, doctor. It is malignant hyperthermia. It is because of a channelopathy, which is because of mutation of the calcium channels which are present in the L tubules, that is rhinodine. So you can see over here, this is the DHP receptor. The DHP receptor is the voltage gated channel. It is also called as a voltage sensor, right? So this we are speaking about the skeletal muscle. Now next question. There is a 5-year-old boy which is brought by the mother which has got a difficulty in walking. He started walking at 11 months of age, and 4 months ago mother noticed that she has got difficulty in raising from the floor. Okay, मतलब जब वो नीचे से खड़ा हो रहा है तो he is not able to stand up, and she finds that the calf muscles have hypertrophied. He carefully raises from the floor supporting himself, as the walking is as if he is trying to climb. This is a very typical walking of which condition? The options are titin, dystrophin, desmin or actinine. So which substance is found to be deficient? The clue given to us is a boy. Very good. Dr. Naruto has given. Naruto. I hope I'm, so very good. I really want to appreciate this fast answers. Very good, Seema. Very good, Raj. So it is nothing but is Duchenne muscular dystrophy, which is a very severe form of a muscular dystrophy, which is characterized by the mutation of the dystrophin glycoprotein complex. And इसमें 5-year-old boy is a very important clue, because this disease is X-linked recessive. Okay, this disease is X-linked recessive. Next, the first heart sound coincides with which part of the cardiac cycle? Isovolumetric contraction, relaxation, early filling or diastasis? Bolo. The first heart sound. Now, if we remember, the first heart sound is because of the closure of the AV valves, that is closure of the tricuspid valves and the mitral valves. This is the beginning of ventricular systole. Ventricular systole begins with isovolumetric contraction, so the correct answer definitely is A. So what we'll do, we'll just have a look over this Vigor's diagram where we try to just sort out. So when you look over to the Vigor's diagram, it is very complicated. We get scared, but just don't get scared of it. Okay, now you see over here that this is the point where there is closure of the AV valve. Now closure of the AV valve means production of the first heart sound, that is the beginning of the systole. So this is ventricular systole. This is a mechanical event, and it will always be preceded by electrical event, that is QRS complex. So you will first get a QRS complex on the ECG, closure of the AV valve S1, and rise of pressure of the ventricle, that is isovolumetric contraction. The pressure will rise, and there will be opening of the aortic valve, and then there will be beginning of the ejection. So the QRS complex on ECG, S1, and you are going to get the closure of the AV valve and beginning of isovolumetric contraction. At this particular point, you will also find that there is C wave in JVP, because the C wave of JVP also occurs in isovolumetric contraction as the tricuspid valve is closed, and it results in a small but very sharp rise of pressure in the right atrium. So the things which are coming will be S1, QRS complex, C1, and the closure of your valve. So these three things are coming in sequence. So cardiac cycle ko now when you are learning for MCQ, learn through the sequences. You are not supposed to give an LAQ, but obviously it will be sequences kind of question. Now, which of the following is an extrinsic clotting factor? So, certain topics which are very important and repeatedly coming are acid-base balance, calcium, questions related to your clotting system. These are something. Yes, Dr. Noto has come with the first answer. Very good. It is factor 7 which is important. Factor 7. Like Unesi has come. Very good. Good. Yes. Now, this question is very important. So, So you must remember that the factors which are involved in the extrinsic pathway, okay, the factors which are involved in the extrinsic pathway are, extrinsic pathway begins with a tissue trauma, okay, with a tissue trauma. So this involves the tissue factor, factor 7, factor 10. So the main important factors over here are 7 and 10. Now this one, that is the formation of the prothrombin activator and conversion of the prothrombin to thrombin, this process is common, okay, this process is common to the intrinsic and the extrinsic pathway. It is common to both the intrinsic and extrinsic pathway. सो मेन हमको ये पता रखना है कि कौन से फैक्टर्स हैं जो एक्सक्लूसिवली इंट्रिंसिक में है और एक्सक्लूसिवली एक्सट्रिंसिक है. Similarly, just have a look over the factors which are involved in your intrinsic pathway. The intrinsic pathway, which begins when there is contact with the blood vessels with a collagenous substance. I mean the contact of the collagen with blood trauma when there is there. So this involves the factors 12, 11, 9, 8 and 10. Then 5. So can you say that factor 10 is common to both intrinsic and extrinsic? It is common to both intrinsic and extrinsic. इसके बाद इस टॉपिक को लर्न कैसे करना है? You must be very clear that which factors are involved in the intrinsic pathway, which factors are involved in the extrinsic pathway. Second thing that you must remember, that factor 5, and this is the process which is common to both intrinsic and extrinsic. The third thing that you must learn is which are the tests, for example the prothrombin test or the partial thromboplastin time, which are the tests which are particularly relevant to the intrinsic and to the extrinsic. So this is the way the the question is asked, or this is the way the topic has to be learned. Then factor number 13, that is your fibrin stabilizing factor, is a very important factor because it helps in the formation of the cross-linked fibrin fibers, which is responsible for the strengthening of the the strengthening of the clot, right? Next one, what is true regarding creatinine? The creatinine clearance is less than inulin, it is more than inulin, it is equal to inulin, or it is none of them is the correct answer. Next important topic which is repeatedly coming is on the clearance. This is a topic which is repeatedly coming. Yes, definitely. So the correct answer is that creatinine clearance is more than inulin. So when you take the clearance of inulin, it is 125 ml per minute, that is just equal to that of GFR. But that of the creatinine is 140 ml per minute, but that is also normal because creatinine is a substance which is secreted. So the clearance 140 with creat is very normal, or is correct. I mean, you will not say that the GFR is deranged. Now practically, we say that inulin is the gold standard, right? Inulin is the gold standard, but practically what we used is creat. The reason is that it is an endogenous product of muscle metabolism, so you don't have to give it extragenously to the patient, so that risk you are reducing, and so creatinine is preferred. Recently there is another factor called as the cystatin C. Okay, cystatin C, which is supposed to be a new marker for GFR, and serum creatinine is a very significant indicator of the kidney function test, because creatinine totally depends upon GFR for its excretion. So serum creatinine ka level is one of the important one for the kidney function test. Now, what is the function of utricle and saccule in the inner ear? Linear acceleration, angular acceleration, or helps in hearing the low frequency sound, or amplify or reduce the sound. So this utricle and saccule, they are the part of the vestibular apparatus of ear along with the semicircular canals. Very good. So the correct answer is A. The semicircular canals, they help in detection of angular acceleration. That means suppose if you are rotating your head, the entire rotation of the head is angular or the rotational acceleration. The utricle and the saccule, they detect linear acceleration. For example, you are moving up and down in the lift, okay, you are moving in the car, or just experience the झूला, Columbus, ऐसे बड़ा सा कोलम्बस जो है, that में you are exciting your saccule and utricle. These are the sensory organs, and the receptor responsible, like in the semicircular canal, the receptor responsible is the crista ampullaris, whereas the receptor of the utricle and the saccule is macula. And here I would take sometimes sometimes I would take a question on the on the photoreceptors, that is the photoreceptor potential, and also I would like to take the tip link theory. So anytime you get one term that is called as the tip link theory, the tip link theory is associated with the ear, where this is the relationship between the stercocelia and the kinocilium. Now, what is the cause of death in a patient with diabetic ketoacidosis? Dehydration, cerebral edema, hypokalemia, or sepsis? So the important or one of the common cause of death, more responsible in diabetic ketoacidosis, is supposed to be cerebral edema. Very good, Pankaj. So Pankaj has come up with the first correct answer. Great. Very good, Pankaj. So it is cerebral edema, which is most common. Now, which of the following statement is true regarding GFR? So when there are multiple questions, you have to be very, very careful to select. Increase in the renal blood flow increase GFR. Increase in the sympathetic function leads to increase in GFR. Afferent arteriolar constriction leads to increase in GFR, or decrease in the renal blood flow decreases GFR. So what is the correct answer? Very correct answer. The two answers are very, very close to each other. There will be one answer which is totally out of question and one is confounding. So सबसे ज़्यादा confusing answer, दो options सबसे ज़्यादा confusing होंगे. Yes, very good. So the correct answer is increase in renal blood flow will cause increase in GFR. The renal blood flow and GFR, both of them are actually regulated together, and both of them show a phenomenon that is also called as auto-regulation. Now, if you look into your GFR, you will see that there are Starling forces which are working here at the level of the glomerular capillaries and on the level of your Bowman's capsule. You have got PB, that is hydrostatic pressure of the Bowman's capsule, which decreases GFR. You have got P, that is hydrostatic pressure of the glomerular capillaries, which actually increases your GFR. You have got pi G, that is colloid osmotic pressure of the glomerular capillaries, which decreases GFR. But here in the Bowman's capsule, the pi B is always 0, because the proteins are never filtered and they are never coming over here in the Bowman's capsule, right? They are never coming here in the Bowman's capsule. So the force, or the Starling force, which is responsible, not normally responsible for regulating GFR, is your pi B, that is the colloid osmotic pressure of the Bowman's capsule. Similarly, PB, that is the hydrostatic pressure of the Bowman's capsule, which decreases GFR, is also not a very physiologically regulating factor, because this hydrostatic pressure increases only when there is urinary obstruction. This urinary obstruction can be either because of presence of some calculi, right, or it can also be with benign hypertrophy of prostate. So any such condition which is increasing the back pressure increases the hydrostatic pressure of the Bowman's capsule and decrease your GFR. That means this is also not a force that is regulating your GFR. So what are we left behind is only the hydrostatic pressure of the glomerular capillaries. hydrostatic pressure of the glomerular capillaries, which is the factor that is a physiological regulator of GFR. And remember, afferent arteriolar dilatation will increase, whereas mild efferent arteriolar constriction, remember constriction, will increase GFR. But if you bring about a severe constriction of the efferent arteriole, it decreases the GFR. So you must remember that the efferent arterioles have got a dual role, right? They have got a dual role. That means mild will increase GFR but severe will decrease GFR. Another important thing, efferent arteriolar का आपने constriction अगर किया तो renal blood flow will be decreased. But again, this is something very conceptual and I have to take it as a separate lecture. मतलब अभी एकदम से जल्दी I cannot tell you, because you have to understand this topic. If you really need this topic, I can take it as factors affecting GFR. You can let me know. Now, next one, the large wave on JVP is due to tricuspid regurgitation, aortic regurgitation, atrial fibrillation or tricuspid stenosis. The next very important and repeatedly asked question in FMG screening exam is your JVP. क्या है बेटा correct? Yes, definitely yes. Very good, Yogesh and Seema. The correct answer is tricuspid regurgitation. Now remember that this JVP is also called as the central venous pressure, right? It is also called as the central venous pressure, which is reflecting the pressure of the right atrium. If you have to know the pressure of the left atrium, you have to speak about the pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure. That is the pressure of the left atrium. Why do you take it in the right internal jugular vein? Because it has got a direct communication with the right atrium. Also remember that the venous pulsations are seen better than felt. Okay, are seen better. That means they are better visible, but the arterial pulsations are better felt. So this is a very significant difference between the venous and the arterial pulsations, that the arterial pulsations are well felt but the venous pulsations are well seen. Jugular venous pressure shows 3 positive waves A, C, V and 2 negative waves, that is X and Y, and this is one of the very important image based question also. For example, I may just hide this wave and I may ask you what is the cause of this wave. So you should know that यहाँ पर जो first elevation है या जो first positive wave है वो हमारी है A wave, ठीक है? This is the A wave. The cause of the A wave is atrial systole. The cause of the C wave is the closure of the tricuspid valve during isovolumetric contraction, and this tricuspid valve, it bulges into the right atrium. The V wave is because of venous filling of the right atrium. X wave is due to atrial relaxation, and Y wave is when the blood comes from the atria to the ventricles. नैरा आपने एक बहुत बड़ी गड़बड़ की बेटा. Dicrotic notch is this, which is the part of the aortic pulse tracing. बेटा aortic pulse tracing में आपको dicrotic notch मिलेगा. That is also called as incisura. So this is a very very common error which students do. देखो मैं आपको दिखाती हूँ नायरा, क्योंकि आपने गलत लिया तो आई थिंक मेरे को अब भी आपको दिखाना पड़ेगा. ये देखो, यहाँ पर आएंगे हम. ये देखो नायरा, दिस इज बेटा नाइक्रोटिक नॉच. This is the dicrotic notch, which is because of the closure of the semilunar valve, that is the aortic valve, which is with the aortic pressure tracing. Very very common mistake which is done, and I'm really happy that Naira has made this mistake, so at least we could rule out. Is it clear, Naira? Yes, but I hope it is very, very clear now. Samjha? Now, which of the following hormone has a positive effect on LH just before ovulation? Yes, that's good, you know. Sometimes mistakes are actually very good. Very good. So Deepak बोल रहा है प्रोजेस्ट्रॉन, ईस्ट्रोजन, प्रोजेस्ट्रॉन, FSH, ACTH. कौन सा आंसर करेक्ट है? पॉजिटिव इफेक्ट ऑन LH. Now, the positive effect on LH, which is called as the LH surge, which is called as the LH surge, which is very, very important for ovulation, which is around 13th to 15th day, is because of estrogens. Very good, Yogesh and doctor. It is because of estrogens. This is a very important question which also comes as an image-based diagram. Now, if you consider the female reproductive cycle, the pre-ovulatory phase is estrogenic phase, which is also under the control of FSH, because this is the phase where there is formation of the follicles, right? Which is the phase where there is formation of the follicles. So the pre-ovulatory is a rise in the estrogen and the FSH. Rather, as soon as there is onset of menstruation, you will see that the FSH level, it starts rising. That FSH is very important to bring about the growth and development of new follicles, right? And then estrogens will rise to bring about the proliferative changes in the endometrium. Just at the time of ovulation, normally estrogen does not rise LH at all, but what happens is that during ovulation, or when the ovulation is about to happen, the estrogen causes rise of this LH. If the LH is not raised, there will be no ovulation. So after ovulation, there will be formation of the corpus luteum, which will then secrete abundant of progesterone. So the post ovulatory period, which is also called as the secretory phase, is because of progesterone, and you will see that at that time there will be a decline in the level of FSH also. So maximum FSH is in the pre-ovulatory period. This is again very important. इसके साथ में जो एक और बात हमको याद रखनी चाहिए, that during ovulation there is a rise in the basal body temperature, right? Basal body temperature rises because of the thermogenic effect of progesterone. Also remember that there will be cervical mucus changing, the spin-bucket phenomenon, the thinning of the cervical mucus, which are signs of ovulation. Apart from this, nowadays transvaginal endoscopy, transvaginal USG is done for the ovulation studies, which is very, very important test for infertility. Now, next one. A patient has got unilateral drooping of eyelids with muscle weakness, with headache, and symptoms they worsen during evening. This is a very, very important clue, that the symptoms they worsen with evening. The patient feels better after taking neostigmine. What is the probable cause? Lambert-Eaton syndrome, ophthalmoplegia, myasthenia, Becker's. Very good. Oh my God, very good. So what should I give all the bachas over here? Yes, I can really treat you with this. Very, very good. Wonderful. Wonderful answers. It is definitely myasthenia. So remember, when there is a history that the person feels fatigue, or the symptoms they worsen towards evening. Okay? To add on this, the person feels better with rest. These go towards your myasthenia gravis. On the other hand, if the symptoms are that after exercise the patient feels better, after exercise the patient feels better, this becomes your Lambert-Eaton syndrome. So Lambert-Eaton syndrome, there is mutation of the calcium channels That means presynaptically it is present, right? You know that this is the calcium channels, voltage gated calcium channels, which are present over here. All right, these are the voltage gated calcium channels which are present over here. So these channels, they get affected in Lambert-Eaton syndrome, whereas post synaptic nicotinic cholinergic receptors in myasthenia. Apart from this, another thing which occurs at the level of NMJ is the botulinum poisoning with flaccid paralysis, because botulinum inhibits the release of the presynaptic vesicles. It causes interference with the docking proteins. So if it is a botulinum kind of a question, the clue which will be given to you is food poisoning. The patient has eaten something, uncooked food, undigested food, that will result in that. Now, next important and a repeatedly asked question is on general physiology related to the concentration of ICF and ECF, related to action potentials and osmolality. So which component increases plasma osmolality? Glucose, bicarbonate, sodium, or proteins? Which is the correct answer? Now, this question is really very important. The correct answer is sodium. The plasma osmolarity is in the range of 280 to 290 milliosmoles per liter. Out of this, around 220 milliosmol contribution is only by sodium. So sodium is your primary determinant of osmolarity and of your ECF volume, right? Plasma proteins, they have got high molecular weight and they have got high concentration, right? High concentration and a high molecular weight. But when you speak about molar concentration, the molar concentration of the proteins is very, very, very low, very low. See, if there is NaCl and this NaCl is put into water, you will get 2 osmoles. 2 osmoles, 1 sodium, 1 chloride, because sodium is always bounded with something. But if you put 1 albumin will give only 1 osmole of albumin. So the molar concentration of the proteins is very less. Therefore, their contribution to osmolarity is less, whereas the maximum contribution to osmolarity is your sodium. Is it clear? Dr. Naruto, who was confused like this, he has put, and I hope it is clear now, because there is no doubt about this question that the maximum contribution to osmolarity is your sodium. Clear hua beta? Yes, very good. Next, in liver, bacteria that enter through the hematogenous route are removed by which cells? Camphor, dust, hepatocytes and endothelial cells. So sometimes you can really imagine what simple questions can be a part of the examination, and when the questions are very simple, we are more in doubt because we are never imagining simplicity in questions. It is camphor cells. So remember, the mononuclear macrophage or the reticuloendothelial system must also be read. Now, which of the following is true about the function of antiporter? One molecule goes in, other molecule goes out, both go in, both go out, or one molecule goes in and the two exit out. You will see that even in the NEET PG, there are repeatedly questions coming over transport mechanism. Very common. 2-3 साल से I'm observing that questions are coming over general physiology. Yes, very good. So this is the antipoter with us. This is the antipoter, wherein one molecule, okay, wherein one molecule, for example, this is the sodium calcium exchanger. So sodium and calcium, both of them are moving in opposite direction. Similarly, sodium hydrogen exchanger, whereas this is a symporter or the co-transporter, where both the molecules are coming inside, right? So that is a symporter. Remember, these two become example of a secondary co-transport or secondary counter transport, and they are energy dependent, but they are using energy indirectly. Why indirectly? Because they are not causing a direct breakdown or a direct hydrolysis of ATP, but they are using the energy that is being developed in the form of gradient by the primary hydrogen ATPase pump. Now, the stretch stimulus is mediated by muscle spindle, Merkel's, Meissner's or Pacinian. Yes, very good. Nessie has come with the correct answer. Good. So it is definitely the muscle spindle. Muscle spindle is again very important and repeatedly asked question. Go through your FMG exams के question. You will find that if bar you are getting a question on muscle spindle, then the stretch reflex and the inverse stretch reflex. So this is the muscle spindle which is present inside the muscle. Okay, this is the muscle spindle. So to differentiate from the regular contractile units, this is the regular contractile unit, and you call them as extrafusal ordinary muscle fibers. Extrafusal, the actin, myosin, they are supplied by alpha motor neurons. Okay, alpha motor neurons. Naira Ruffini is for sustained touch and pressure. It is for sustained touch. It is for pressure. It can also, it is also good when to find out the shape of objects grasped in your palm. Okay, so that is the function of Ruffini's, and Ruffini's is a it is a it is a long lasting, or it is a tonic tonic receptor. Okay, slow adapting receptor. It is a slow adapting deep receptor. Deep, and it is a slow adapting receptor. Right, now, so extrafusal muscle fibers, that means the regular contractile unit, that is actin, myosin, which has got innervation by the alpha motor neurons. On the contrary, you have got this intrafusal, which have got innervation gamma motor neurons. Now within this is the central portion or the equatorial portion, which is non-contractile, which is actually nothing but this is your muscle spindle. This muscle spindle detects the stretch of the muscle, or it detects the muscle length. Length can be both static as well as dynamic. Now, which of the following has got a maximum smooth muscle? Respiratory bronchiole, alveoli, terminal bronchiole or alveolar ducts? Which of the following has a Now, This is very important. Yes, definitely it is your it is your yes, it is your terminal bronchiole. Now, do you know that what is the Webbel's model? There is a Webbel's model for respiratory tree, wherein Webbel had divided the respiratory tree into 23 generations. Okay, into 23 generations, where the trachea is the 0 generation and your alveolar sacs or the alveolar ducts will be your 23rd generation. From 0 to 16th is the point where there is terminal bronchiole. So from the 0 to the 16th is the anatomical dead space. This portion is called as conducting zone, and the volume is 150 ml, or the volume of air which is present over here is 150 ml. It is called as the conducting zone because it is only taking part in the transportation of the gases. There is no exchange of gases over here. There is no exchange of gases. It becomes the conducting zone. The terminal bronchiole, that is the 16th generation, is the site where there is maximum smooth muscle, and this is the area which is subjected to maximum bronchoconstriction and bronchodilation, right? So when we speak of bronchoconstriction or bronchodilation, it is this area, that is the terminal bronchioles, which is maximally subjected. From 16 to 23 is the respiratory zone, where there will be presence of the respiratory bronchioles which take part in exchange of gases. Also remember that the sympathetics, they cause bronchodilation, whereas the parasympathetics, they cause bronchoconstriction. There is something which is called as non-adrenergic and non-cholinergic. Non-adrenergic, non-cholinergic neurotransmitter or a chemical transmitter which is known to cause broncho-relaxation or bronchodilation. The correct answer is VIP, that is vasoactive intestinal polypeptide. Okay, so non-adrenergic, non-cholinergic is the VIP. Next one, 125 dihydroxycholecalciferol, that is the active form of vitamin D, is regulated by PTH, calcium, magnesium, or 25 hydroxycholecalciferol. Yes, very good. It is maximally regulated by PTH. It is not by vitamin D also. मतलब यहाँ पर अगर मैं एक ऑप्शन रखती हूँ विटामिन D, right? If I keep one option as vitamin D, then also the correct answer will be PTH. Remember that as soon as there is a decrease in the level of calcium, the first hormone that will be released will be your PTH. It will never be vitamin D. This PTH will then result in the formation of the active form of vitamin D, which takes place in the PCT of kidney, in the proximal tubule of kidney, right? And as soon as there is an increase in the calcium level, the first hormone to be raised is calcitonin. Now, which of the following plays a role in exocytosis? Again, exocytosis means a kind of a vesicular transport. So what is it? Calcium, magnesium, sodium, or potassium? Yes, definitely the answer is calcium. Remember that the vesicular transport mechanisms, they are also a type of active transport mechanisms. Okay, they are also active transport mechanisms. Next one, enzyme colipase enzyme polypase is present in bile, saliva, succus entericus or the pancreatic juice? Sometimes the questions are really very simple, and once the questions are very simple, we are actually confused कि इतना simple question कैसे आया है, and we try to find out some answer which is actually not related to it. Yes, very good. It is the pancreatic juice, and definitely this is the hormone enzyme that helps in fat digestion. Next. The dense bodies which are present in the smooth muscles are present where? A band, Z line, M line or H band? Now, the correct answer is Z line. If you look into the sarcomere of the skeletal muscle or of the cardiac muscles, that is in the case of the striated muscles, this is a sarcomere which is present between two Z lines, and you will have the actin, myosin. Okay, you will have the actin and myosin. Now, in the case of the smooth muscles, in the case of the smooth muscles, the Z lines are absent. There is no, a regular horizontal alignment of sarcomere in the smooth muscles. Instead of Z lines, what do you get are the dense bodies which are giving attachment to the actin, and here in the center you can find myosin. So one difference in the smooth muscle is absence of the Z line, and instead of Z line you have got dense bodies. Second is that the calcium binding protein is calmodulin. So the troponin which is present is absent in the smooth muscles. Third important point, the sarcotubular system is very poorly developed. Instead, what you will find is this calveoli. These calveoli are actually representing the rudimentary T tubules. Okay, so these are the very, very important differences in the smooth muscles as compared to the striated. So we had 1 hour session, and I had tried to take in as much as possible. I will be covering many more questions of last 5 years in my successive or the upcoming classes. Meanwhile, if you have anything that you want I should teach you, please put it in the comment box. And what I always say is, please be persistent in your studies. Learn discipline. Why you want to be disciplined? You want to be disciplined because you love yourself. That is the most important thing. That why am I disciplined? I'm disciplined because I love myself. I want to become something, right? I want to improvise myself, and therefore I am disciplined. Remember, our parents keep on scolding us, do this, do that, don't do this, don't do that, because they love us and they want to become a better version of what we are. So why don't we, why don't we love ourselves and become so much disciplined that we are the best version of ourselves? Lots of blessings, love and best wishes, boys and girls. The teacher feels very, very happy. तबीयत का ठीक होना नहीं होना is something very different, but taking the class is the best thing that happens to me. This is my best medicine. The more I teach, the more I learn. So I just love teaching classes. Eunice, my best wishes are always with you. They are always with you, always in prayers. I always keep my students in my prayers, because if my students win, I win. Remember, your victory is my victory. Okay, your victory is mine. So I'm selfish and therefore I want that you should win, because if you win, I win. So I sign out and we see very, very soon. God bless you all. Happy learning. Thank you.